Right now, high-performing behavioral health practices are losing up to 20% of their collectible revenue. That is 1 out of every $5 left on the table. This deficit does not reflect poor clinical care. It is a direct symptom of preventable, systemic billing errors baked into standard administrative workflows. We can track the secondary symptom of these errors straight to cash flow. In 2025, the average accounts receivable cycle for behavioral health practices spiked to 65 to 75 days. This chart compares that reality against the broader industry baseline. While more than half of all U.S. healthcare organizations now report overall denial rates exceeding 10%, the behavioral health sector sits uniquely in the 65 to 75-day AR range. Prior authorizations compound the delay. 93% of physicians report that navigating these specific payer requirements directly delays patient care before a claim is even generated. Extended AR cycles drain operational cash flow. When payments take 2.5 months to land, your staff is forced to spend their afternoons chasing aging claims instead of processing new, clean ones. Behavioral health practices are quietly bleeding cash because their in-house administrative workflows are failing to keep pace with a highly aggressive payer environment. Many practice owners assume that a highly competent general medical biller is equipped to handle a psychiatric practice's EMR. The data proves otherwise. Unlike general medicine, psychiatry lacks standardized coverage rules. United Healthcare might accept a combination of therapy and medication management that Aetna actively denies. Each payer sets distinct contradictory policies. The primary friction point sits entirely within time-based psychotherapy codes, specifically the 90832 through 90838 series. This diagram shows the anatomy of a single time-based psychotherapy code. The precision required here is absolute. The session length must perfectly match documented start and stop times, and it must stack with specific evaluation and management modifiers. Missing a single layer triggers an automatic claim denial. Even minor oversights are fatal to a claim. Submitting one outdated diagnosis code for depression or PTSD under the newly introduced 2025 subcategories guarantees a rejection. The massive scale-up of telehealth has added a final layer of modifier confusion. Applying the wrong place of service code or botching modifier 95 drove a recent 84% surge in at-home telehealth denials. Behavioral health coding requires hyper-specialized logic to navigate payer-specific rules. It is structurally incompatible with a generalist billing workflow. Attempting to solve this complexity by hiring an in-house behavioral health coder is economically unsustainable for most mid-size practices. Base salaries for this level of expertise range from $55,000 to $75,000 annually, and that is before factoring in benefits, payroll taxes, EMR software access, and training time. This creates what we call the staffing spiral. A practice invests months training a new coder on their EMR and payer mix, only for that coder to leave for higher-paying hospital systems due to fierce market demand. Then the practice starts over. High-performing practices abandon this strategy in favor of credentialed arbitrage. They shift the function from a high-overhead internal employee to a specialized outsourced team. This is not generic outsourcing. The model strictly utilizes AAPC and AHIMA-credentialed specialists who work exclusively within the behavioral health and psychiatry space. These credentialed specialists understand exactly how to pair new add-on codes with telehealth modifiers. They are the single biggest driver of high first-pass claim resolution rates in the industry. Moving away from the generalist in-house model mathematically eliminates the high costs of employee turnover while drastically driving up claim accuracy. In the current payer environment, generating a flawlessly clean behavioral health claim requires absolute precision. This side-by-side comparison shows a standard medical claim on the left versus a modern behavioral health claim on the right. The first architectural requirement for the behavioral claim is stacking time modifiers perfectly alongside complex evaluation and management visit overlaps. The second requirement is applying the newest 2025 ICD-10 subcategories for conditions like prolonged grief and generalized anxiety, completely bypassing the outdated default codes sitting in your EMR. The third requirement is isolating prior authorization workflows. These authorizations must have clear ownership and strict follow-up timelines satisfied before the patient ever enters the room. Executing this three-part architecture consistently across hundreds of patients requires a dedicated operational engine. A diligent office manager simply does not have the bandwidth. A clean claim is the mathematical result of layering highly specialized logic over every single patient encounter. Overhauling a practice's revenue cycle follows a strict 14-day transition period managed entirely by the specialized team. Step 1 is the kickoff call, where the specialized team comprehensively maps the practice's unique workflow and payer mix. Step 2 establishes secure, encrypted EMR connections within 48 hours. Step 3 is team onboarding. The outsourced specialists are strictly trained on the practice's specific clinical protocols and quality thresholds. Step 4 is go live. This is the moment daily coding and quality reviews officially begin. Step 5 deploys the KPI dashboard, providing the practice's management with weekly reports on throughput, accuracy, and ROI. The most critical operational advantage is that the specialized team works natively inside your existing EMR, whether that is Epic, Athena, or eClinicalWorks. There is zero software migration required. True workflow integration ensures the clinical team experiences zero disruption, while the administrative coding risk is entirely transferred to the specialists. Processing massive claim volumes without degrading accuracy requires technological leverage. Specialized teams utilize AI-augmented workflows, beginning with smart routing, that automatically assigns the most complex payer mixes to the right specialized coder. Here we see an outgoing claim scanned by an automated pre-submission audit. These systems predictively flag modifier mismatches and documentation gaps before the claim ever reaches the payer. AI is not replacing the coder. It acts as a defensive shield that supercharges the AAPC credentialed specialists' speed and accuracy. The mathematical outcome of this paired system is definitive. According to Deloitte, practices utilizing automated pre-bill audits prevent up to 85% of avoidable denials. Layering predictive AI over deep human specialty expertise forces error rates below 1%. This model restructures the financial reality of running a practice. Securing a dedicated, specialized coding seat costs just $399 per week. This system brings massive scale and stability, having been successfully deployed across more than 800 practices nationwide, and that scale operates safely. The entire infrastructure runs strictly under HIPAA, SOC 2 Type 2, and HITRUST compliance frameworks from day one. Every day spent ignoring structural billing complexity is another day earned revenue is quietly surrendered to payers. Review your denial data. Stop accepting 65-day AR cycles as normal. Visit the URL on screen or call to initiate your 14-day risk-free pilot. Modernizing a behavioral health revenue cycle is the ultimate defense of your practice's financial survival.